that I think a lot of us are interested in anterior approach because of its, documented, proven, and largely well accepted role in reducing one of the bigger complications of total hip arthroplasty. I'm going to present my biased perspective on approach to instability, understanding that my thoughts are my own, shared with a few other faculty, but other people will have their own approaches on how to manage or reduce the incidence of instability. Nothing relevant for this talk. So the risk of instability with the anterior approach is going to vary depending on what study you read, but if you look at high volume, experienced centers reporting their results, here's one 0.4% risk. Here's a second 0.6% risk. Here's a third 0.5% risk. So these are clearly, in established centers with surgeons well out of their learning curve, you can get well below 1% risk of instability consistently in high volumes of patients. And I think this is great, but there's a quote from I believe it's Vince Lombardi. Perfection is never attainable. George Hadikevich and Christoph were discussing whether we can ever get to zero here. Perfection is never attainable, but if you chase perfection, you will achieve excellence here. And I actually think we can do a little bit better than this with anterior approach. So here's my personal strategy, developed underneath and in conjunction with Jose Rodriguez, who's going to talk in a minute. But it's a 5-step strategy to really try to get this number down to zero. I tell patients if they have a dislocation, it's on me. If they have an infection, it's just random, but they have a dislocation, it's on me. Preoperative planning, soft tissue preservation, your anatomic socket positioning, which Jose talked about yesterday, really optimizing the bearing diameter and